Welcome to the Cardinal Minute with your host and chair of the University of Louisville Department of Medicine, Dr. Kim Williams.
And good morning, and welcome to a Cardinal Minute. I'm Dr. Kim Williams, chair of medicine here at University of Louisville, and it's my pleasure today to introduce our speaker for our Charles Smith Lecture, which occurs annually here for our grand rounds. And our speaker is Dr. Scott Kaatz, and he is the clinical professor of medicine at Michigan State University and my alma mater, Wayne State, where he actually is a hospitalist and is the medical director in professional development and research at Henry Ford Hospital. And he actually spoke this morning about treatment of VTE, venous thromboembolism, and periprocedural anticoagulation management. Dr. Kaatz, can you give us a 1-minute summary of your talk?
Yeah, well, thanks so very much, and I really had the pleasure also of learning about Dr. Smith and his legacy that he's had here within the community over the years. I think a couple of brand new stuff would be a couple of things. We have a trial now that just came out this year that is talking about maybe you shouldn't reduce your dose of a direct oral anticoagulant after the first 6 months or so. But I think there's some statistical nuances in that trial that you have to be careful at looking at the results of the trial and then what I think we should use. And the reason is it showed that reduced dose is actually pretty safe, but it did not meet statistically the safety parameters compared to full dose. But I think the big reason is because their rates of recurrence, a good thing for the patients, it was so low. And we get into that crux that, oh darn, we didn't have enough events to prove statistically, but we didn't have enough events is a good thing from a clinician. So, and we had a signal for less clinically relevant bleeding. So what I'm doing with that new trial is I'm still dropping my patients down to half dose after 6 months for a non-provoked venous clot, whether it's pulmonary embolism or deep vein thrombosis. Another question that is really very informative that just came out is a trial looking at what do we do in the patients with cancer-associated venous thromboembolic disease. And can we use a lower dose similar to this study in that very high-risk population and still not get an excess of clots but cut down on the bleeding? We know the cancer patient has lots of clotting and lots of bleeding. And that trial showed just 12 days ago from when we did this lecture that you didn't lose anything in efficacy and you gained stuff in safety. So that is one of those about every 1 or 2 times a year. I don't know about you, but I get a practice changing trial that, I move, and this was one of those trials. So I am now become comfortable with doing that in my highest risk. And then the last study that just came out this year in 2025, a pilot study, was really looking at how long should we hold a direct oral anticoagulant before we go to surgery and invasive procedure. And the anesthesiology group and the American College of chest physician groups are at odds a little bit with this. This study compared those two different holding parameters and found that the proportion of patients that had very low DOAC levels was the same, about 95% in each group. So I think there's been this yin and yang and sort of a bit of butting heads between the two societies, and this study is giving us some clues that there's really maybe no difference at all. So whichever way people want to go, it's probably okay.
Well, this was really fantastic. It's a very fluid area. We have to make sure we're not clouded in our thinking. Thank you very much. This has been a Cardinal Minute.